start the session by a talk of Professor Dr. Sobky about his experience, 40 years experience in management and observation of DDH. Welcome, Dr. Sobky.
السلام عليكم. يعني دي presentation يعني عن our experience in DDH surgery. We have a long experience. طبعا كان زميلي العزيز رحمه الله عليه الدكتور يحيى طراف هو اكتر واحد كان بيشتغل DDH surgery، ولكن كمان انا كنت بشارك في حالات كتير، فيعني بنقدم شويه in our experience. I had my training in hip surgery with Anthony Catterall in London in the late 80s, and he told me that the most important thing in DDH surgery is to have a stable concentric reduction in the true acetabulum. ما ينفعش ان احنا في اخر العمليه ان الهيب ما يبقاش resting peacefully in the socket. نقعد نزق ونشد ونمسك بوايرز وبتاع. It doesn't work. So long you have done a proper job, the hip, the femoral head should rest in the socket without any thing to do. Our approach in the young kids below 12 months is an open reduction through a medial approach. We don't usually use the Ludlow approach. We use the modified Wettstein approach. So we go in the plane between the pectineus and the neurovascular bundle. I feel it's an easier way. You get directly on the psoas tendon and then you get into the capsule. I found it easier. But not a lot of people they share the same idea. This is a case of left DDH, 9-month-old male, and this is the post-op X-ray and the CT. We always do a CT to ascertain that we have a concentric reduction, because an X-ray is not a definite proof that you have done a proper concentric reduction. We always do post-op CTs. This is the 2-year follow-up. There is no avascular necrosis and doing well, and the gait of the kid. Beyond 12 months, we do a single stage open reduction, femoral and pelvic osteotomy and capsulorrhaphy. We have changed the indication of the femoral osteotomies. We don't do now a lot of femoral osteotomies. This is a case of 3.5-year-old female with right DDH, a bit unusual. At surgery, definitely the head was deformed as expected in a 3.5-year-old girl. And this on the right side, this is the reduction at the end of the surgery. This is on the image intensifier. The post-op X-ray, good reduction. And a 3-year follow-up, definitely there is evidence of healed avascular necrosis of the right femoral head as expected in a 3.5-year-old girl, but still clinically she was doing quite well and her gait is near normal. When we have studied our apparently successful cases, we found a lot of residual hip dysplasia that we could not really find a reason for them, but they were there. This is a case, a 2-year-old female with left DDH. On the right side, there's an intraoperative image, intensifier picture showing good reduction. At 2-year follow-up, there is definitely very severe avascular necrosis with severe hip dysplasia. We decided to do a shelf osteotomy, and this is the intraoperative image intensifier photo showing good coverage of the hip. At 8-year follow-up, there was definitely avascular necrosis with coxa brava and a prominent high GT. So we decided to do a retrotracheal screw epiphysiodesis with screw and washer. 2 years later, it didn't work, so the picture was the same. So after the closure of the apophysis, we decided to do a distal transfer of the GT, and this is the X-ray showing healing of this. And this is the girl walking. She walks quite nicely, and she's a bit skinny, unhealthy, but she walks okay, and she has a negative Trendelenburg test. She will show us now. Now she stands. Okay. This is the left, yeah. She's doing well.
يلا تعالي حبيبتي يلا تعالي عليا.
It's another case, 15 month female with left DDH. 1 year follow-up after a full-scale surgery, open reduction, DEGA, and femoral rotation osteotomy. Excuse me. At 4-year follow-up, we found a left coxa valga, which is a common thing that we usually see in a good percentage of cases. So we decided to start to use the medial screw hemiphysiodesis using cancella screw into the medial side of the epiphysis just to correct the coxa valga. And this is 2 years later, it's improving. But there is a problem here that the screw gets short, so we need to change it. So this is a big problem that you need sometimes to change it once or twice. This is another female, 18 months, with left DDH. She had a full-scale surgery, femoral derotational osteotomy, open reduction, and DEGA osteotomy. 6-year follow-up, she was doing quite well, but some AVN. The problem 2 years later, at 7 years, she developed a limb length discrepancy of 2 centimeters, but the girl was really upset. Usually the 2 centimeters does not create a real problem, but this young girl was really upset, so we decided to do an ipsilateral epiphysiodesis to correct the limb length discrepancy. A year and a half later, she developed coxa valga, so we decided to do a medial screw hemiphysiodesis, and this is 2 years later, and it's correcting nicely. But because of the change of the screws, we decided to use the new free gliding Scaffi screw because we don't have to change it, so it works nicely. This is one of our first cases, but it was a spastic diplegia, and we had the coxa valga, and we used this Scaffi screw to correct the coxa valga. This is a study was in Scottish Rite Hospital. They're comparing the late outcome of open and closed reduction. In 104 closed reduction, they got a 47% of reconstructive surgery for dysplasia and a 43% of residual dysplasia in the hips followed until trilateral closure. These are the closed reduction. They do a lot of closed reduction in Scottish Rite Hospital. Whereas in the 54 open reduction, they found only 30% of residual of secondary surgery for residual dysplasia and a 36% of residual dysplasia in the hips followed until trilateral closure. We did a study which was published in 2013 comparing the outcome of the DEGA and Salter osteotomy when used with, in treatment of DDH with the open reduction. We found no difference between both osteotomies, except that in the Salter osteotomy, we need to do a second surgery to remove the K-wire because we don't believe that we need to leave the K-wires outside the skin. This is a very bad thing not to be done. This is a paper by Pablo Castaneda. This guy, he does a lot of hip surgeries. He works in New York. And he found that the femoral shortening does not really prove that you have a better outcome when you do a femoral shortening. So we don't need to do routine femoral shortening as we used to do some years ago, that we do always a 1.5 centimeter shortening just to lessen the tension in the femoral hull and to use it in the DEGA osteotomy. to do ephemeral deglutitional osteotomy or not, this is I think very debatable, but this is a study from India by Muta et al. And they found that you don't need to do ephemeral deglutitional osteotomy, especially in the young kids, because they do well, especially if you put the limb in internal rotation in your cast. This is a case of left DDH, done only DEGA and open reduction, no femoral osteotomy, and this at 8-year follow-up, doing quite well clinically, and this is the gait is quite well. This is another 16-year-old female, 16-month female with left DDH, open reduction and Salter osteotomy. Very rare for me to do Salter osteotomy, but this girl, we did a Salter osteotomy, and this is at 9-year follow-up. She's doing quite well, but very strangely, although we did not do ephemeral deglutitional osteotomy, she had a very evident left out towing. This was quite common in the cases where we did the rotational osteotomy that developed out towing, but this girl didn't do ephemeral deglutitional osteotomy, still she had left out towing. In these neglected DDH beyond the age of 2 years, usually they are different because it's difficult to keep the head in position, and the biological remodeling that usually occurs in the younger patient does not occur. But still, despite that we did a lot of older patients, we still had excellent good results in accordance with a paper published by Çiçekli and Dogan from Turkey that they had the same results. This is a 5.5-year-old female with bilateral very high dislocation. Usually in these kids, we need to do a CT scan pre-operatively. This is her gait before surgery. Definitely, she's not very happy. At surgery, the femoral head was really deformed as expected. She had an elongated ligamentum teres, and we had to do a 4-centimeter shortening in order to attain a consented reduction of femoral head. 3 weeks later, we did the left side. These are the X-rays post-operatively showing consented reduction of both hips and the CT, as we said. And 3 years later, she was okay. Definitely, there is some various degree of vessel necrosis, but she's doing quite well. And she came to remove the plates and screws. And this is her gait, quite satisfactory for such a difficult case. This is another girl, 9-year-old female with right DDH, very severe hip dysplasia. This is her gait pre-operatively. She had severe limping, and she's very unstable. She needed some help to walk properly. At surgery, the head was really deformed, not only deformed but ulcerated from the long-standing dislocation. And this is one of the very few cases that you use a Kirschner wire to maintain reduction, because even after the DEGA osteotomy and the derotational osteotomy, the femoral head was not stable in this socket, and we had to use the Kirschner wire. And this is the post-operative X-rays and CT. And at 6 months follow-up, definitely there was avascular necrosis, but the head was still in its socket, but unfortunately, we don't have a longer follow-up for this case. When you see that this are all regular DDH, but on the non-idiopathic DDH that are not really the regular ones, you need to be very careful. This is a girl, 40 years old female, with bilateral high dislocation, and these are the post-op X-rays after surgery of both hips. 1 year later, she developed relapse of both dislocation, which got worse after 3 years. So we decided to do a muscle biopsy, and it turned out to be a congenital myopathy case. So this is very important that when you suspect that the case is not a straightforward case, you should do your proper investigations, at least to inform the parents that this is not a regular standard case. This is a paper by Luther et al. They said that the neuromuscular condition is not the etiology of the hip dysplasia, but they are rather coincidental finding that the dysplasia is not a result of the neuromuscular disease. This is another paper by Gatti, published last June, that he says that when you have failure of your usual standard procedures, you should always think that there is something wrong, that this is a non-idiopathic case. But still, not all the myopathic cases they do badly. This is one of our patients. She was 3 years when she presented to me. This young girl has a family history. Her mom and her sister, they have myopathy. And this is she had bilateral procedures at 2 weeks interval, and the CT shows concentric reduction. At 9-year follow-up, when she came to me just a month ago, she had reduced hips, although definitely there is the diminution of the joint space, but definitely she is okay for her case. But she developed a nasty scoliosis, but nobody wanted to operate because she has myopathy. And this is her gait. She walks. She walks without aid. She's fine. For her case, it's okay. She does well. This is another very, very tricky case. This is a girl presented to me at the age of 2 with bilateral hip dislocation. After examining her, I thought definitely she's a case of myopathy, but I did an EMG. I found a normal case. She had only just severe hyperlaxity, and this is the day of surgery. She's unable to, she's wobbly, and she needs bilateral support. We did the right side first, full scale surgery, and then the left side and the CT showing good reduction. And this is at 2 years and 5 years follow-up. She's doing fine, but still there is some dysplasia in the right hip, but she's doing fine. And this is her gait. Still very wobbly, but she walks alone. For me, it's okay. Our preferred technique below 12 months is an open reduction through a medial approach. After 12 months, we do only open reduction pelvic osteotomy and capsulorrhaphy. No female dilatation osteotomy except in the patients above 4 years. It's very important to deal with these cases early before walking age. Around the walking age, you have much better results. The atypical risk factors did not seem to badly influence our results. Ephemeral osteotomy is not a standard part of our approach. We do it a la carte if you need, usually not before 4 years. In the neglected cases, we still have good results when you do a full attack, open reduction, femoral shortening, derotation, and pelvic osteotomy. You can have quite good results, very encouraging. And always in the cases that doesn't look normal, always think of this is not an idiopathic DDH cause. It might be a neuromuscular problem, and should always inform the parents that everything is not really 100% guaranteed. Thank you very much.